Yeah, hi. So my name's Raheem, and I'm doing the presentation with Krithika as well. And so yeah, it's
Hello.
part of the teaching series. So this one today is on neuroimaging, but I think the last one was on chest X-ray interpretation. So some of you might have been in that one as well. And then we've got one of the consultants from Leicester here as well to answer any questions if there are any that come up. Um, So yeah, we'll just start if that's okay. So the main things we're going to be going over are the types of neuroimaging modalities, how to identify normal neuroanatomy. So we're going to mainly focus on CT today. Um, we have a bit on MRI as well, but it's mainly focusing on the CT. And then we're going over stroke, a little bit of stroke management, but mainly focusing on the imaging part. Um, and then we'll switch over to hemorrhage. There's a few cases throughout, and that should be it. And then if you could scan this QR and fill it out either as we're going along, or just before we start, that'd be helpful. So we'll start off with you've probably already been over this before in like phase one lectures, but just the basic differences between a CT and an MRI head. So CT head, you've got a more limited soft tissue resolution, and then when you're thinking about the brain, obviously soft tissue. So um, you get a less detailed visualization versus the MRI, which would be more detailed, and then you can pick out the brain structures a bit more easily there. So it's better for identifying normal and abnormal anatomy. CT, you've got less detailed visualization of the spinal cord for the same reason. Uh, and then the benefit of the CT is good visualization of bone structures versus the MRI. And then the way they work is different as well. So you've got radiation, so it's like taking multiple X-rays in a given plane and then adding them together is how you get the CT versus the MRI, which uses magnetic fields. And then you can use the magnetic fields and like manipulate them a bit differently to get a different image out of the MRI. The good thing about CT, especially in terms of like stroke, would be it's good for identifying like hemorrhagic strokes quickly and just generally for identifying hemorrhage quickly. Um, and then the MRI would be better for like identifying early ischemia, especially if it's like smaller areas as well. So the imaging modalities, like a bit more in detail. So CT, you can adjust the contrast of the images to get a better image of certain structures. So you can see here, um, you've changed the contrast in these images. So um, it's the same scan, but it's just the contrast been adjusted on these top two here. So you've got the brain window and then a bone window. So you can obviously tell, pick the different structures from the same image. And then on the bottom, you've got the MRI sequences, which is where you manipulate the MRI frequency pulses and the magnetic gradients to produce different images. And then that can highlight different properties like edema. And then you've got the different types. So you've got T1, T2, and flare. So T1's good for things like showing anatomy, and that's where fat is bright, water is dark. And you've got T2 where it's good for showing edema and swelling, where water's bright. And then you've got flare, which is like T2, in the water is bright, but it suppresses, sorry, it's the other way around. So it's like T2, but it suppresses the water, the CSF to dark. Um, like if there was any edema, it would be dark rather than bright. And then if anyone could put in the chat which imaging modality they think the first one is, and which plane they think it is. So if they like, start off with the easier one, so which plane do you think this image is taken in? You can put on your mic or just put in the chat, or if not, I'll just go through it. Yeah, so there is the first image, which is yeah, you've got coronal and then axial, and then the imaging modality. So like whether it's an MRI or a CT. Yeah, that's good. Yeah, T1 MRI. And then the second one, if you could put in the chat whether that's an MRI or a CT, and then which plane it is as well. So the first one, so this first image here, it was a T2 MRI. And so the way you can tell that is by looking at the color of the CSF. So you can just see the CSF looks quite bright there, whereas it would be dark on a T1. So it's that one is a T2 MRI head. And then the second image at the bottom of the screen, that one is a sagittal T1 weighted MRI. And that's because you can see that the fluid's quite dark, the fat is white, um, and then with the grey and white matter, the grey matter, which is on the outside of the brain, is dark, and the white matter, which is on the inside of the brain, is bright. Um, yeah. Um, and then, yeah, we can move on from that. So I think one like good way to think about it is that um, if you're trying to distinguish between the grey and white matter and the different types of like weighting, it's just to remember that the white matter that's on the inside of the brain is myelinated, which is like we learn it as being like a fatty sheath. And because of that, it means it's brighter on T1, which enhances fats on the scan. Um, and then just a bit on the neuroanatomy before we get on to strokes. Um, so yeah, we've got a few images there on the right hand side. And a few things to be aware of when you're interpreting the scans is just to orientate yourself with the anatomy. So you've got the different lobes of the brain. So the frontal, parietal, temporal, occipital lobes. Um, and then technically the limbic and insular as well, but um, I don't think that's very important. And then like a clinical like relation of knowing these parts of anatomy is that if you can recognize that there's cortical atrophy, so if you can recognize widened sulci on the scan, you might be able to pick up some cortical atrophy, which is a feature of a few different conditions. Um, and does anyone know what the name of the sulcus is that separates the frontal and parietal lobes? If they put it on the chat, or if you want to use mic, that's fine as well. So yeah, and then the fissure that separates the frontal and parietal from the temporal lobe as well. So that one's I think it's on there. So it's the lateral fissure. So you've got the central sulcus is the one that separates the frontal and parietal, and then the lateral fissure is the one that separates the temporal from the frontal and parietal. Um, yeah, it's fine. So some other structures to be aware of would be the deep gray matter. So it's important in conditions like Parkinson's. So you've got the basal ganglia, which that's made up of the lentiform nucleus, the caudate, the substantia nigra, and the subthalamic nucleus, and then that communicates with the motor cortex via the thalamus, and it helps to either reinforce appropriate movements, the direct pathway, or remove inappropriate movements with the indirect pathway. And then something to be aware of when you're thinking about like strokes would be that the thalami are sensory relays, so they coordinate the afferent or the signals that are coming towards it, and that can cause sensory loss when those are damaged. And then we've just got the diagrams on the side as well. And then one way that you can distinguish the different parts of the deep grey matter, because I think they can be sometimes quite different to distinguish, is just based on the location. So if you're aware of the anatomy, the caudate's more medial and next to the lateral ventricles, but the putamen is a bit more lateral. And then that's separated from the caudate by the internal capsule, which you can see on the diagram on the top there. And then I'll just quickly go over a few of the white matter structures as well. So some of the white matter structures would be the corpus callosum, um, the internal capsule. So the internal capsule you can identify because it separates the caudate from the putamen. And then obviously you've got the different divisions. I think they should be, yeah, they're marked on the bottom stand there with the anterior limb, the genu, and the posterior limb. And the function of it is that it carries the corticospinal motor fibers, some sensory fibers, and corticobulbar fibers as well. And then it's important because in conditions like a lacunar infarct, um, you can get pure motor strokes if it's just in the posterior limb, and if it's in the genu, get like facial weakness with corticobulbar tract involvement. Um, so yeah, just being aware of the different fibers that are in the different parts um, can be important. And then the corpus callosum. Does anyone know what the function of the corpus callosum is in the brain? You put in the chat or just use mic, it's fine. Yeah, so communication between the two hemispheres, good. The two hemispheres of the brain. And then if we move on to a few other structures, so brainstem and cerebellum. So the structures to identify there would be the midbrain. So the function of the midbrain is eye movements and reflexes to sound and vision. And then the pons, which is to do with like sleep and feeding, and then the medulla, which is like has cardiovascular and respiratory centers. Um, the diencephalon containing the thalamus, hypothalamus, and the third ventricle. It's like another structure to be aware of. Um, yeah, we can move on. So yeah, just the different presentations there. So like if you had pontine hemorrhage, it can lead to things like locked-in syndrome, where the patient can only um, communicate by like eye movements. And then you've got the cerebellum, um, the different parts of that, and it's in the posterior fossa. So you've got the white matter afferents and efferents, and if you have damage there, it can cause the like Danish symptoms. Some people refer to it as so dysdiadochokinesia, ataxia, nystagmus, intention tremor, scanning dysarthria, and hypotonia. And then just the scan there that shows them. And then we have a few labeled CTs here of um, the ventricles and cisterns. It might be a bit difficult to see, so I don't think the images are that big. But would anyone be able to put the number in chat of which one they think the lateral ventricles are? So there's quite, I think there's three or four numbers on each image. Um, the lateral ventricle should be in the bottom right image, labeled there. So it's either 61, 62, or 63. Um, yeah, so that's 62 is the lateral ventricle. It's good. And then the third ventricle should be visible on the bottom left image. So is it either 39, 40, or 41? Yeah, so 39. And then just the last one, the fourth ventricle. So is it either 25, 26, 27, or 24? Yeah, that one's 26. That's good. So the ventricles and cisterns, they're important to identify when you're thinking about things like hemorrhage and hydrocephalus. Um, so yeah, we've got the lateral, third, fourth ventricles, and then just to re-go over like the anatomy and the drainage. So the CSF in the lateral ventricles drains into the interventricular foramen, um, which then goes into the third ventricle, and then that drains into the cerebral aqueduct. That drains into the fourth ventricle, and then enters a subarachnoid space via the two lateral and then one midline aperture, and then that goes into the to like surround the brain and spinal cord. And it's just important to know that when you're thinking about blockages to the system. So I think there's a few ways you can like go about interpreting a CT head. I think maybe at our stage, having something like this mnemonic is probably quite helpful. So you've got the like looking at the blood first, so see if you can identify any blood in the brain. So it'd be so if there's somewhere like you're expecting it to be darker, if you're seeing it like lighter, then maybe suspect density blood. Look at the cisterns, look at the brain itself, so the tissue. Look at the ventricles, so the lateral, third, and fourth ventricles that we looked at on the slide before, and then look at the bones. So can you see any breaks anywhere? Maybe any thinning. So we've got this case here. It's an abnormal CT of the head. It's axial. Um, and then we've got a bit of a like history as well. So you can have a look at the image, and then if I give you a history of this image being from a 34-year-old man who presented to the emergency department with 3 months of sudden severe headaches. He reports that the pain comes on abruptly. It lasts several minutes and then gradually settles. He has these episodes several times a week, which are consistently worse when he's sitting or standing. The pain sometimes improves when he's lying flat, and he describes brief bouts of nausea with one episode of momentary confusion. And on examination, he's alert and oriented. His fundoscopy showed mild papilledema, but his neurological exam is otherwise normal. So, I'll give you like a couple of minutes to think about it. And then if you just put in the chat what kind of things you're thinking about. So if we go through it using like the mnemonic of blood, cisterns, brain, ventricles, and bone, does anyone see any like blood anywhere on the CT? And you can just put in chat if you do. And then does anyone see anything wrong with the cisterns? Don't think there's actually any visible. Um, does anyone see any issue with like the brain tissue itself? And then does anyone see anything wrong with the ventricles? So they should be, yeah, so that's good. They are enlarged. And do you know which one that is? Oh, I think it's just giving it away, but yeah, so the lateral ventricles are enlarged. Um, and it says, yeah, there's an obstruction there. Do you know what that obstruction might be? So you've got like quite a well-rounded lesion there, at the level of the foramen of Monro or like interventricular foramen. Do you know what that could be? It's in the brain. So it's reported as a colloid cyst. That's what's causing the obstruction and the dilated lateral ventricles. That's leading to an intermittent obstructive hydrocephalus, and then that's what's causing his symptoms of intermittent headache, and improving when he's lying flat. Yeah, we can move on. So into strokes. Um, just a basic definition. So, a cerebrovascular event that's caused by abnormal perfusion of cerebral tissue, causing sudden onset of rapidly developing facial or global neurological disturbance lasting more than 24 hours. That's what distinguishes it from a TIA. It's the length of time. Sudden onset, focal, unilateral weakness or sensory loss. You get aphasia or dysarthria, ataxia, vertigo, loss of balance, visual problems like amaurosis fugax, when the retinal artery is occluded, um, which is like a curtain descending. You can get diplopia or you can get homonymous hemianopia. You don't have to have like all of these features. It's just a few that are possible. Does anyone know what the amount of ischemic to hemorrhagic strokes there are? So like what percent of strokes in general are ischemic and what percent are hemorrhagic? Just like a guess. Yeah, that's about right. So yeah, about 85% ischemic and then 15% hemorrhagic. And then you've got the different stroke classifications. So you've got posterior, so PACS, POCS, LACS, TACS. So posterior anterior, anterior split into total anterior and partial anterior. Then you've got lacuna as well, and then you've got the different clinical features of them, which you can have a look through. And then obviously because they're affecting different parts of the brain, they're going to show up differently on CT and MRI. And then just a general initial management strokes. If it's an ischemic stroke that's been identified, so there's no like hemorrhage visible on the non-contrast CT, then within 4.5 hours you give aspirin 300 milligrams, thrombolysis, and statins. Should be after 48 hours. So yeah, first line imaging. If you're suspecting an acute stroke, is non-contrast CT. It's really important to get that to rule out hemorrhage and then enable your decision. It helps you to decide whether or not you're going to start thrombolysis. If you're suspecting a large vessel occlusion, so like a high NIH-SS score, so NIH stroke scale score, or if you're considering a thrombectomy, then you might request a CT angiography as well, alongside that, without delaying the initial non-contrast CT. And that can help to localize where the occlusion is and assess the vessels and collateralization. MRI, so the different types, diffusion weighted, flare, and MRI. So that's if you have a CT, but you can't identify the really small infarcts, or just to clarify, other conditions that you're considering alongside stroke. So if you haven't managed to distinguish between stroke and other conditions, can help with that. And then CT perfusion, that's for core versus penumbra assessment to select patients in longer time windows. So if you're outside the usual time window of a thrombectomy, which is like usually I think up to about 6 hours, or late reperfusion. And then so the core is the brain tissue that's already been infarcted or it's about to infarct, regardless of whether you give any reperfusion treatment or not. So it's suffered severe irreversible ischemic injury and it's not going to recover no matter what you do. And then the penumbra is a surrounding region with critically reduced blood flow that's functionally impaired, but it's still metabolically active. So it could maybe make a recovery based on the actions that you take. So some red flags to be aware of on stroke imaging. It's probably most important to be aware of the signs on a non-contrast CT because that's what you'll see most often. If you see an active intracranial hemorrhage, first thought is to not thrombolize. You need to urgently reverse any anticoagulation. So like warfarin, any of the DOACs, things like that. They need reversal immediately and contacting neurosurgery as soon as possible and intensive care as well. If there's a large established infarct with mass effects, so you can see a visible midline shift on imaging, that's high risk for malignant cerebral edema. You need to escalate to senior stroke and neurosurgery for potential decompression with a hemicraniectomy is like one of the possible options, and critical care. Hydrocephalus, if you see that on scan, then urgent neurosurgery escalation might also require decompression or CSF diversion, and contrast and vascular findings that suggest an unstable patient. So if they've got really bad findings, like vascular findings, then you prioritize an urgent thrombectomy and you inform the center that are going to do the thrombectomy that there's a lot of risk. So there's a few cases on stroke here. We'll just try and go through them quickly. So there's a 70-year-old male that's presented with a sudden onset, severe left hemiparesis and loss of sensation on the left. There's a previous subarachnoid hemorrhage, and they've been put in a CT scanner 2 hours from the onset of their symptoms. can anyone like point out where they think there's a lesion? Yeah. So right-sided parietal, yeah. So right-sided parietal hemorrhage with surrounding edema, and then there's a bit. It's been reported as having a bit of a mass effect as well. So I think there is a bit of a midline shift visible there. Um, yeah, good. Um, so next one, case two. There's an 85-year-old female with acute onset dense left hemiplegia, which means like severe left hemiplegia, and it's predominant in her lower limb. She's got slurred speech, and this is what her non-contrast CT looked like 6 hours after onset. Um, and then you've got the different stroke classifications, um, which might help deciding um, which vessels were affected. So in that case, you can see circled there on the scan on the left. Um, she's been given a CT arterial phase, so that's just highlighting the arteries um, in the brain, and you can see there's a density. Um, obviously, the blood's going to show up as density because it's an arterial phase scan, but it kind of stops. Um, that's where the circle is. It looks like the blood flow stops, so it's called like a hyperdense artery sign, and it's in the right middle cerebral artery. So that's a middle cerebral artery infarct, and then that's caused you can see the darkening of the grey matter on the outside in the other scans. So it's the MCA that's been occluded. That's caused the infarct in the brain and the tissues that the MCA supplies. And then 24 hours later, after she's been given 300 milligrams of aspirin loading dose, which is um, what's commonly given to stroke patients, ischemic stroke patients. She had a progression, so it's now transformed into a hemorrhagic stroke. So the infarcted core that she had is now hemorrhagic. And then what actually happened with this case is apparently she wasn't a candidate for thrombolysis or endovascular clot retrieval due to frailty, and a palliation um, decision was made. So we'll move on.
Okay, so now we're going to talk about some of the different types of intracranial bleeds that you can get. We're going to discuss the four main ones. And in terms of where these bleeds are found, you can quite easily distinguish this from their names. So if we start with extradural, it's found outside the dura, so it's found between the skull and the dura mater of the meninges. And this is usually due to the rupture of our middle meningeal artery. Subdural is the same, so if you break down the name subdural, it's found under the dura, so between the dura and the arachnoid. And this is usually due to the rupture of a bridging vein or multiple bridging veins. Next, we have intraparenchymal, and this is bleeding within the brain parenchyma itself. And this can present similarly to an ischemic stroke. So if you find someone presenting with stroke symptoms, it's an important differential to rule out. And then finally, you've got subarachnoid hemorrhage, and again in the name, so under the arachnoid so bleeding within the subarachnoid space. So if we look at these closer on imaging, you can see that with extradural, blood that collects in the extradural space is quite limited in how far it can shuffle laterally. And this is because the dura inserts itself at suture lines. And so blood is limited by these lines. And you see, when blood can't move laterally, it moves medially, which creates the concave hyperdensity that you can see in the images below. And quite often these are described as lemon-shaped. So it's quite nicely sharply demarcated on the imaging below. Hold on. One second. So next you've got our subdural hemorrhages, and these are not limited by our suture lines. And sometimes you can't appreciate it that well on the images below, but they're described as banana shaped. I've got an image later on in one of the cases where you can see that banana shape a bit more distinctly. The important thing to note with subdural hemorrhages is that between 3 and 21 days, sometimes the density will drop. So it's not seen as that homogeneous hyperdense area that you'd usually see, but it might become isodense. And this is because the body has had time in those days to break down the hematoma. Something that you'll see on both of these is a mass effect, and you'll see the falx cerebri, as you can see in the third image from the left, shifts because of the midline shift pattern. So in terms of imaging with intraparenchymal hematomas, you can often describe them as an irregular shaped density. On the first image, it's within the left cerebrum. And you can see it's surrounded by a hypodense region just below, and this is known as blend sign. So it's basically you've got your hyperdense blood surrounded by your hypodense edema. And then in terms of your subarachnoid hemorrhage, the subarachnoid space contains your CSF, your major blood vessels, and your cisterns. And so when you have bleeding in a subarachnoid hemorrhage, your blood will fill those cisterns, and it results in a 5-point star pattern that you can see on both images quite nicely. So we're going to move on to some cases. So the first case is a 54-year-old woman who presents to the emergency department with a sudden onset severe occipital headache that began while she was climbing the stairs. She describes it as the worst headache of her life. She's had one episode of vomiting. She lost consciousness for 20 seconds, and on examination, she's photophobic with marked neck stiffness. In terms of her OBS, her rest rate is within the normal range, but slightly on the higher side. Her blood pressure is high, her heart rate is also high, and her temperature and her oxygen sats are okay. There's no neurological deficits on examination. So the first question is, we've got our CT scan. Can someone either with your mic or on the chat describe the CT scan and state what our most likely diagnosis is? Okay, so this was a bit of a trick question because this is a normal CT scan. And I put it in just so you know that it's good to see normal, but also sometimes in subarachnoid hemorrhages, which is the most likely diagnosis, CT scans will appear normal. The reason why the most likely diagnosis is a subarachnoid hemorrhage is based on the history. So we've got, first of all, they're more common in women. Second of all, it's a sudden onset severe headache that she describes as the worst of her life. And also she's got features of meningism, so she's photophobic and she's got neck stiffness. So because the CT scan is normal, can someone state on the chat or with your mic what the next initial investigation would be and what's the minimum time interval you'd want to do this investigation? Sorry, what are the two white dots in the normal CT? Hold on, let me have a look. So I believe they are blood vessels, but Dr. Lam might be able to comment further. Choroid plexus.
Yeah, can you hear me?
Yes, yes.
Yeah, they're normal. They calcify it sort of in your early to mid-20s, and you find them in the lateral ventricles. They can be ignored.
Anyone know what the next investigation would be and how quickly we would want that investigation to be done? Yes, lumbar puncture is correct, Prishni. We'd want this to be done within 12 hours. And the reason we want, sorry, not within 12 hours, after 12 hours. And the reason we'd want this to be done after 12 hours is to give time for the lysis of red blood cells and release of bilirubin. And I've sort of given away the answer to the next question with that. So name two findings you'd find when you did a lumbar puncture on this patient with suspected subarachnoid hemorrhage. Xanthochromia is correct, Max. And that's because, as I said, you get breakdown of bilirubin, so your CSF will turn into a yellow color. You would also get increased opening pressure and raised red blood cells. And that's because of the increased pressure of the CSF and formed due to the subarachnoid hemorrhage, and then also breakdown of red blood cells will lead to increased red blood cell count. So, can anyone tell me what the most common cause of subarachnoid hemorrhage is? It was on the previous slide, and what medication can be given to reduce the risk of cerebral ischemia? Verapamil is not what I was thinking. Berry aneurysm, Prishni, is correct for the most common cause. The medication that's usually given is nibodipine, which is a calcium channel blocker, and this is used to help reduce the cerebral vasospasm, and so it's reducing the amount of blood going into your brain. So it's trying to alleviate the pressure on your brain when there's an increased pressure. Okay, two more cases left and then we'll be done. So the next case is a 22-year-old man. He's brought to A&E. He's fallen over, struck the right side of his head on the ground. He was unconscious for about 30 seconds, and then he's recovered quite quickly. 10 minutes later, he becomes a bit more drowsy, starts deteriorating. He's got a headache and vomiting. So in terms of his OBS, his respirate is within the normal range. His blood pressure is slightly on the higher side. His heart rate is low. And he's got right-sided scalp swelling, unequal pupils, right pupil dilation, and left-sided weakness. So again, having a look at the CT and what I've just told you about intracranial bleeds, can someone quickly describe the CT and state what the diagnosis could be. Left epidural hematoma and mass effect is wonderful, Max. So, yeah, you've got your left-sided hyperdensity and convex edge lemon-shaped lesion consistent with our extradural hematoma. Oh, the other thing you can see is if you look outside the bone, you can see there's quite a bit of hyperdensity, slight hyperdensity outside the bone, and that's just soft tissue swelling outside next to the hematoma. So, what features of the history support our diagnosis of the epidural hemorrhage? I'll just put the history back up for you. So there's one feature that's quite pathognomonic of our epidural hematoma on the history. Yes, that's correct, Max. So we've got our lucid interval, which is where you are knocked unconscious, you wake up, and then you start deteriorating again. That's wonderful. And which vessel is most commonly involved with epidural hematomas? Yes, that's correct again, Max. Middle meningeal artery. So this is usually after temporal bone fracture, the weak region known as the pterion. And another thing to look out for when you're looking at a CT scan, you're seeing an epidural hematoma is so using our mnemonic of blood can be very bad. Looking at the bones, you might be able to see a fracture line. On this image, you can't, but if you were to look at another image, it's another thing that you need to keep in mind. Okay, a bit more of a complex question. So why is the patient's heart rate low? So the patient's heart rate is 58, which is slightly on the bradycardic side. And after that, can we name a complication of an epidural hematoma if it's not treated promptly? Yes, that's correct, Prashni. So raised intracranial pressure can lead to bradycardia, and that's because of Cushing's reflex. So it's vaguely stimulated, and you have an increase in intracranial pressure, and that leads to a triad of signs, bradycardia, high blood pressure, or hypertension, and then you'd also get irregular breathing. And then, sorry, I didn't give us a chance to answer what complication could occur, but the complication that's common is brain herniation, and that can be subfalcine uncool, depending on the mass effect that the hernia the hematoma creates. Okay, we've got our final case, so we're nearly done. This time it's a 79-year-old man who's brought to A&E. He's confused, he's unsteady for the last 3 days. He's had a minor fall, but he didn't lose consciousness, and so he didn't seek any medical attention. He's got a PMH of hypertension, AFib, moderate alcohol use, and he's on rivaroxaban. In terms of his OBS, we have got a rest rate of 18, blood pressure, which is quite high, heart rate, which is within the normal range, but irregular due to his atrial fibrillation, and the rest of his OBS. He's got a bit of a low temperature, but apart from that, his OBS are normal. So we know the drill. So we've got our CT scan. Can we describe it and state the most likely diagnosis? subdural is correct, Prishni. Max is typing. Left hyperdense area with mass effect. Yes, that's correct. So earlier I was saying that with subdural hematomas, you can quite often see a banana shape, which you can see quite nicely on this image here. And you can see the left-sided hyperdensity, and it's not sort of constricted by suture lines. So we've got our nice hyperdense lesion from the edge going inwards. So what vessels are involved in subdural hemorrhages? And if I go back to the history, there's multiple features, but name a feature in the history that supports our diagnosis. They're on anticoagulation is one of the features. Confused and unsteady is also a feature that supports our diagnosis. So with subdurals, bridging veins are the ones that are most commonly involved. And then, as I said, with the histories, you got anticoagulation, you got confused. He had his recent onset of head trauma, which was a while ago, and then also his age. So yeah, very well done, guys. And then how does anticoagulation with rivaroxaban increase the risk of subdural hemorrhage? So what I want to know is sort of how rivaroxaban works. Like what factor does it inhibit? And then why having rivaroxaban can lead to a hemorrhage. Factor 10A is correct, and it interrupts clotting cascade is also correct. So it's a direct factor 10A, and then it prevents thrombin from being formed, and so prevents clot formation. Okay, and the final question, you'll be glad to know, is the patient's going to be sent for surgery, but if they rapidly deteriorate before surgery, what are basic bedside management techniques you can use to help reduce the intracranial pressure? So there are a few things you can do. Hyperventilation is correct. And the reason that this is good is because it reduces your arterial CO2. And so your cerebral arteries will vasoconstrict, and this will reduce blood flow to the cerebrum. So it's going to mean less blood goes to the head, so less volume and less pressure. Elevating the head is also correct, and that's just gravity. It's going to help reduce it's going to help your venous drainage, but it's also going to help CSF move down as well. And the final thing you can do is hypertonic saline, and this works because it creates an osmotic gradient. So you're pulling all the water from your swollen brain tissue into the blood, into the intravascular space, and then you're reducing the edema on the brain. So that's very well done, guys. You answered all the cases very well. That completes our talk today. Any questions, feel free to pop your mics on and ask, or put it on the chat. If you could also scan our QR code just so we can know how we can improve our future sessions, that would be greatly appreciated. We've also got a few references, but I'll pop back the QR code so you can scan it.